My name is Jennifer Rioux. I'm a medical anthropologist, doctor of Ayurvedic medicine and yoga therapist, and a whole systems, mixed methods, and ethnographic researcher. I'm going to speak on integrative healthcare, traditional world and indigenous medicines, and planetary health. Connecting the educational, clinical, and evidence-generating fields of integrative healthcare is essential for systems change. Currently, researchers don't regularly inform educational curricula, and clinicians are often not closely involved in study design with researchers. Students may learn about systems models or complex multimodal interventions only after they've completed conventional professional training programs. The result is a constant retrofitting of the concerns of the educational, clinical, and research spheres in integrative healthcare. Some of the key players in all three realms of the integrative healthcare paradigm are the scholars, scientists, and practitioners of traditional world and indigenous medicines. The insights provided by educators, clinicians, and researchers in the TWIM fields are frequently excluded from conversations in integrative healthcare and thereby from their potential to enhance health outcomes, the evidence base, and the education of future healthcare providers. Exclusion occurs through various mechanisms: lack of insurance reimbursement, lack of NPI numbers, lack of CPT codes, lack of shared vocabulary, lack of mutual respect, and lack of exposure that promotes openness and understanding. The TWIM paradigms are both nature-based and values-based, rendering them most well-equipped to support the needs of the planetary health model in clinical settings. The focus on treatment of root causes and on tailoring therapies to the individual are hallmarks of the TWIM paradigms that provide a symbiotic approach to treating patients within their environmental context, including family, community, social context, and the biosphere. Planetary health assessments are infrequently operationalized in clinical encounters and not codified in mainstream settings. Educating clinicians on planetary health considerations at the encounter or practice levels has not been prioritized. Planetary health courses and curricular components are rarely included in mainstream degree-granting medical institutions. University administrations continue to overlook the critical importance of this curricular material, even in the midst of worsening health outcomes, spiraling costs, and immoral for-profit healthcare delivery infrastructure, damaging environmental and health impacts of big food and big pharma, and obvious climate and planetary catastrophe. Research on planetary health is increasing in scope and frequency, but is viewed as mostly theoretical by mainstream clinicians who feel overwhelmed by attempting to deliver quality care in 15-minute visits. Provider burnout is informed by all of the above. Yet the key role of TWIM professionals in helping to shoulder the burden of providing quality care, leading to optimal patient outcomes, continues to be ignored, undervalued, and dismissed by mainstream biomedicine. American society is besieged by what I refer to as three primary supremacy projects: racial supremacy, gender supremacy, and class supremacy. These supremacy projects are supported by a fourth supremacy, the project of biomedical supremacy. The role of biomedicine in maintaining imbalanced power structures and control of resources in the educational, clinical, and research spheres cannot be overstated. It has been demonstrated that the evidence base is coded by race, class, and gender by virtue of differentials in inclusion and access that aren't equally distributed. Likewise, clinical care is limited for many by the gatekeeping of the insurance industry and its lobbying arms. In education, inclusion of TWIM scholars, researchers, and clinicians is still underrepresented. TWIM medical systems often originate in communities of color and are grassroots in their implementation. Some TWIM medical systems focus on women providers, such as midwifery or botanical medicine. The power of localized knowledge was suppressed by imperial forces, in tandem with extractive relationships to solidify the under-resourcing of BIPOC communities. Continued exclusion of the TWIM paradigms from mainstream healthcare is an extension and reinforcement of historical race, class, and gender supremacy projects. Healthcare is a human right. How can we best address the multitude of intersecting causal factors in the above scenarios from the perspectives of activist clinicians, activist researchers, and activist educators? What educational demonstration projects clinical exposure models, and research collaboratives can we promote that will spur innovation and full engagement with the medical system elders that represent TWIM? How can we pursue a reintegration of their planetary health wisdom and root cause understandings that will inform a renaissance of appreciation for biodiversity, cultural preservation versus extraction, viewing social context as enhancement rather than determinant of disease, individual environment interactions that nourish and protect, and contemplative practices that build bridges and avoid armed conflicts? Understanding, uplifting, respecting, and deliberately incorporating the nature-based and values-based paradigms of Indigenous and traditional world medicines is one avenue for healing the inequalities and injustices of our current profit-driven healthcare system. Respected clinicians, scholars, and researchers in the TWIM fields need seats at the table in order to imbue the process of healthcare reform with the innately positive and powerful perspectives of the traditional and Indigenous healing wisdom traditions. TWIM practitioners are core allies in healthcare reform who have diligently persevered in centering a relational model of well-being that has protected and preserved individual, family, communal, and biosphere health for millennia. Thank you.